Good evening, everybody. I'm pleased to welcome you to the webinar, which is being presented tonight by Daniel Staetsky. The issue is that at this moment is a rather remarkable moment historically in several different kinds of ways. Obviously, we know about the question of the pandemic. We know about the question of the disproportionate way that the BAME community in the UK has been affected. And we also know that the Jewish community has been affected, and we're going to hear much more detail about that in a few minutes. Before starting, I'd just like to raise one or two background issues. One is that as background to this kind of talk, there has, of course, been a huge amount of work that has gone on in different ways. One way it's gone on is in the handling of the Jewish patients who've been affected. One way has been the way that Jewish doctors have participated, some of whom are with us tonight, in the care of patients. One of them is the way the Chevrot Kadisha in the UK, on behalf of the Jewish community, have handled a huge number of dead and have handled them expeditiously and rapidly as best they possibly can. It's invidious to single out certain people, but Mervyn Hartog and Linda Boxer at the United Synagogue and Sidney Sinitsky have been absolutely remarkable in the way they have coped with an unprecedented situation. And in addition to which, and the Board of Deputies, Daniel Elton has been collecting information and data from all the burial societies in a very, very efficient kind of way. JPR has met this challenge, and it's a demographic challenge, and they've met it again with a rapidity that is unprecedented and is also not matched in other communities who are still trying to get to grips with the ONS data. And it's a personal interest in the issue of Jewish demography, because of course the doyen of Jewish demography happened to be a relative. Sidney Goldstein in the United States died last year. And this is a kind of the demographic standards that he set are the kind of standards that are used by Jewish demographers all over the world. Now, Daniel has done an enormous amount of work on this. He is undoubtedly the expert, and it's really a privilege for us to be able to have the person who really knows and understands this information as it stands before us to give what amounts to virtually its first very major public speaking hearing. So I'll hand you over to Daniel and thank him in advance for the work that he's put in, not in the background, but also the work he's put in preparing for tonight. Daniel.
Thank you. Thank you very much, David, for this very nice introduction. Perhaps before I start, I would like to mention something that amounts to housekeeping points. There used to be a time when people met in the same room. And the housekeeping point for these times was where the fire exit is and what to do in the case of fire. Well, that's irrelevant now. But what is relevant is what happens if my connection fails, which is not unknown. It happens. I don't expect it to fail, but if that happens, then usually, I must tell you, it's quite good, and I will try to reconnect, and I will be back. Normally, I'm back after an event like this within 2 to 3 minutes. So that is a housekeeping point, the one and only so far. Okay, let's begin. Let us begin the presentation. And the first thing that I would like to do is to share with you how I'm going to go about this, the presentation plan. First of all, we are here because, essentially, the Office for National Statistics produced something that is truly revolutionary, which is a full mapping of mortality across ethnic and religious lines. And I will talk about that. First of all, to give credit to them and full exposure to the result, what exactly they say, why, what it all means, and why I'm here as well. So something is obviously lacking And that thing required a reanalysis, which I conducted. I will, then I will focus on how does Jewish mortality compare to the mortality of non-Jews in England and Wales, both with respect to COVID-19 and outside of COVID-19. And then very shortly, I will talk about where next, what is still unknown and what we should be thinking about. And I would welcome the discussion on these issues in particular. So this is how it all started. The Office for National Statistics published a paper which titled Coronavirus-Related Deaths by Religious Group in England and Wales from the 2nd of March to the 15th of May, so the core time of coronavirus epidemic. I must say also that this is a second paper published by them on the topic of ethnic and religious differences. The first actually tackled the question of differences between ethnic groups. And the moment they did that, it became apparent that religious groups, this is the type of analysis they conducted on ethnic groups would be very much welcome with respect to the religious groups, and they repeated the exercise. Now, who started all that? Who initiated all this? How did this happen? This happened that because effectively there was a convergence pretty early in the course of the epidemic between the political will and the technical capacity. Political will being here represented by the request made by the Cabinet Office to the Office for National Statistics to clarify what is happening to the ethnic and religious mortality. And the technical capacity is represented by the very exercise that I'm going to present to you. ONS, the Office for National Statistics, did something completely unprecedented, which is linking the census in England and Wales to the records of deaths. This never happened before. It certainly never happened as part of the state-sponsored exercise. The religious and ethnic differences in mortality in Britain are a researched subject, but they were never researched previously on the scale that the ONS did it right now. Normally, it was smaller scale academic. We have sound results from them, but we don't have the scale of the research enterprise of a kind that ONS gave us this time. Now, this is basically a repetition of my previous point. Now, both the British Jewish mortality and ethnic and religious mortality in Britain, they're not completely unresearched subjects. They are. The remarkable feature of the ONS enterprise that it allowed estimation of British Jewish mortality with a truly unmatched degree of precision. All previous research projects in this area, and part of them I initiated, part of them I carried out myself, suffered from, or I wouldn't say probably suffered, but had empty in them. And I will tell you a little bit more about why that was. With the ONS exercise, there's no now, we know we managed to give, that particular exercise gave us unprecedented insight into the Jewish mortality and removed all possible doubts we could have. Another bit of the introduction, which I think is necessary, why and how did the estimation of religious and ethnic differences in mortality became so difficult? First of all, it's something that's quite demanding in terms of the input of data. Basically, what needs to happen for that to happen is that religion and ethnicity should be collected on official records of deaths, as well as in the census. That's what's happening. And so far, this wasn't the case. In 2001, the census in England and Wales acquired a question on religion for the first time. Then it was repeated 2011. But that never quite happened with records of deaths. The deaths, and by the way, also the birth certificate, do not have the religion question. They do not have the ethnicity question. And really, to carry out estimation of mortality, you need the ethnicity and the religion to be present on both. And if I'm honest, it just wasn't a high priority. Enough was known about ethnic and religious differences, and or it was felt that enough was known. So the political will never quite stretched in this direction. If I'm allowed a guess, perhaps the recent prioritization of this issue has something to do with identity politics. Now, normally, whatever room I speak to, there are people who are excited by identity politics, there are people who are less excited, there are people who are indifferent, but I think we should thank identity politics for moving the ONS, perhaps indirectly, in the direction of this particular exercise. Now, this is a slightly technical point, but I think I would like to say a few words here. Now, to those people who are involved heavily in epidemiological research, these points will be unnecessary. They will appear unnecessary. Those people who are quite far from epidemiological research, they are quite necessary, they're essential. So, because I really, I don't have a full insight of who is my audience today, I will be explaining a thing or two about how we estimate mortality in not quite mathematical, but technical way. So the basic unit of analysis, if you wish, when we measure mortality, when we measure something we call the risk of death, we calculate rates, called R for brevity. For that, we require data on deaths and population counts, and we marry them together. We relate them to each other. We effectively divide the deaths by population counts and express it per 1,000, per 10,000. That is done completely for simplicity. Quite a serious demand here that the deaths and the population counts should be compatible. And it's not as trivial as it sounds. It's another way of saying that they should relate to the same group of people. And in the UK as a whole, in England and Wales as a whole, this compatibility is enforced. It's sort of hardwired into the process. For ethnic and religious minorities, it isn't, and it couldn't be done until now. What I mean by compatibility, and I will give a very, very small example, there are many types, is this. When a person dies in England and Wales, a death certificate is issued. And most people who die in England are people who also live in England. So they lived in England prior to their death. There's a small group of people and small number, relatively, of death certificates that belong to people who never lived in Britain. For example, tourists who came here. For example, and then they died either as a result of an accident or as a result because their time came, or because they came for medical intervention, medical treatment, and this trip resulted in their death. Now, the Office for National Statistics knows who is who, and it makes sure that in calculation of mortality rates, it simply removes the death certificates of people who don't belong here. Otherwise, the death rates will be compromised. Now, with religious minorities, we simply cannot do any of that. And I will say a few more words about it. Now, estimation of British Jewish mortality. As I said, it's not the first time this exercise has been carried out in the history of this subject, but there's a significant difference in in the degree of certainty we had before and now after the ONS work has been carried out. So the left panel tells you how we did it before. Before, in order to calculate death rates for Jews, we married together two completely unrelated, independently functioning sources. The deaths we took from the communal statistics, i.e., the Institute for Jewish Policy Research, and before the Board of Deputies for British Jews, went to burial societies, each single one of them, and collected data on deaths. It happened since year 1965 up until now, continuously. Then we related those deaths to population counts that came to us from the census, from the national census. So these two sources were not related. On the basis of these two sources, we derived the rates. And there was a permanent uncertainty as to, do we describe with deaths and with population counts the same population? For example, is it possible that not all Jews checked themselves or marked themselves as Jewish in the census? How does this impact on death statistics? Is it possible that certain Jews escape Jewish burial and their deaths become invisible to us? What does it mean? How does it impact on our rates? That's the uncertainty. There are many of them, and I'm giving just brief examples of two that we lived with. With the ONS exercise, this uncertainty was removed because the ONS exercise rests on a single source. What they did is they took Census 2011 and simply linked every single individual, Jewish or not, to the vital registration, i.e. data on deaths. And by marrying these sources, they created a single source effectively, on the basis of which they derived Jewish and incidentally non-Jewish rates, and where there's no doubt of compatibility between the two sources. This is the brief look at the ONS findings now. What we see in front of you is what's called hazard ratios, in the way that the Office for Statistics calculated them. You can think, now again, those of you who know what hazard ratios are, please forgive me for this explanation. Those of you who don't, I will only say that you can think about them in a very simple way as relative risks. So, for example, take the Jewish death rate and divide it by Christian death rate. And the result is that, give or take, hazard ratio. On the left panel, you see the results for Jews. For example, the figure there is 2.1. The first figure that you see is 2.1. This is a result of a Jewish death rate being divided by Christian death rate, and it means that the Jewish death rate is twice as high. I have the two figures for Jews. The first, as you can see, it relates to what's called model 1, and another one, which is slightly lower, is 1.9. It's model 6, and I will explain the difference. In model 1, the only thing that's controlled for is age. So age is a very, very strong determinant of mortality, obviously, and you really have to control for age when you compare two groups. So this is a single control, and in this case, Jews and we compare like with like, Jews to like with like in terms of age. Model 6, the second figure, 1.9, is a model where not just age, but other characteristics are controlled for. For example, socioeconomic situation. For example, disability. For example, region of residence. For example, population density and deprivation area where people live. The difference between 2.1 and 1.9 is not very big. So basically we can say with respect to males, there's quite a stable situation, no matter how we turn this crystal ball. Jews appear as having higher mortality than Christians. Now look at the middle and the right panels. They represent respectively the Hindus and the Muslims. With these groups, when they with age controls present, they appear very similar to Jews. Well, Jews appear very similar to them, and that's where the tagline was born. Jews are BAME now. when these results became known, when they became publicized and disseminated by newspapers. Now, with Hindus and Muslims, further deprivation for socioeconomic status, for a place of residence, slightly or strongly reduce their disadvantage in mortality. They don't completely eradicate it, but they reduce it. So each model 6 for Hindus and for Muslims delivers a significantly lower number compared to not fully controlled model. So, as you can see, there are two findings that are looking at us from this. First of all, Jews have a very serious, very significant disadvantage in mortality compared to Christians. And secondly, it's more stubborn than the situation is with other groups. Nothing kills it, really, which means older Jews are worse than older Christians. Educated Jews are worse than educated Christians, etc., etc. London-based Jews are worse than London-based Christians. No matter where we look, we see this very strong disadvantage. I have data also for women. I will not go through it in a very detailed way. The picture is essentially the same. The strength of Jewish disadvantage is less for women, but really the essentials, the picture is the same in essentials, if not in detail. If you ask me now, why is it so surprising? Well, you may ask me why. What makes me so surprised ultimately? So we found that Jews have a disadvantage in mortality. Well, that is because the disadvantaged situation, if you wish, of the Black, Asian, Hindu, Muslim population has been linked justifiably to some sort of material socioeconomic disadvantage. And Jews are not otherwise a disadvantaged group. It's as simple as that. It's very surprising to see something like this in a group that is clearly has superior educational credentials and economic situation. Now, for demographers over and above, Jews are known as what we call long lifers, and not just purely for socioeconomic reasons. By the way, there's a large body of research that stretches back something like 150 to 100 years that tells us that that is the case, no matter which society we look at, whether it's Soviet Union, United States of America, Western Ukraine, 19th century, 18th century. We see that Jews live longer than non-Jews around them. They're sort of a vanguard population. One reason for that, what has been noticed very, very early, is that what's called the avoidable mortality is very low in Jews. Avoidable mortality is probably, it's increasingly better known term. It's a mortality that literally can be avoided as a result of better behavior. For example, avoidance of drinking or substance abuse, antisocial behavior. This kind of things. Now, I hope that it would be of interest to you that the earliest comment to that effect that I found in the literature comes from the arguably less known composition by Immanuel Kant, who wrote, it's actually a collection of his lectures in the University of Königsberg. That collection became known later as a book. It was published as a book called Anthropology from a Pragmatic Point of View. It's a first probably publication in anthropology, who said that women, priests, and Jews do not get drunk as a rule. At least they carefully avoid all appearances of it because their civic position is weak and they need to be reserved. It's a very, very interesting observation. And I'm drawing your attention to it because drinking and whatever, the bouquet of behaviors that come from the uninhibited state, that stem from that state, they are a major contributor to what's called avoidable mortality today and during the time of Immanuel Kant. And Immanuel Kant was the first person who first mentioned Jews in this respect. And secondly, he mentioned 3 groups, women, priests, and Jews, that since his time became quite iconic demographic groups with low mortality. Now, as far as I know, I did not look at any figures, so this is quite an astute insight, I should say. Now, so what is really happening with Jewish mortality in England and Wales? Now, in addition to their publication, which you can download on their website, the ONS produced very rich documentation of their sources, more than they used, more than they actually presented, even showcased. All of that is in the public domain, and I extracted it from there. And that allows reanalysis of Jewish mortality and completely independent conclusions. Now, I will say in anticipation that these conclusions are not in the slightest contradictory with the ones that the ONS decided to present, but they're more nuanced, considerably more nuanced, and nuance is sorely needed, I should say. And that is because now something like a day and a half after the publication of the ONS results, I found this on the social media, okay? I wasn't looking for it. I found it on the social media because I happened to be on the social media on that day. So that is a very advanced or a very clever political use of the ONS findings, and it would be really okay if that was true, if Jews were baying. If they are not, that's really not okay. And to prevent misuse of this kind, I think I felt that we really need to move in the direction of reanalysis and make that public as well. So what is the reanalysis that I offer? I simply take all deaths occurring to Jews in England and Wales between the 2nd of March and 15th of May. All of these deaths ONS gave us. And in contrast to the ONS, I separate them into two groups: deaths from COVID and the non-COVID deaths. To remind you, the ONS worked just with deaths from COVID. All of their conclusions and their report relate to deaths from COVID and differentials in deaths from COVID. I take both COVID and non-COVID deaths. I then calculate the underlying population, and I will explain in a second what it means. Obviously, to calculate meaningful death rate, we need to come up somehow with the approximate number of people, Jews, alive on the 1st of March. Now, how do we know how many Jews are alive on the 1st of March? The problem with knowing that number is that the last census that we had is in 2011. So almost 9 years passed since that census. A lot could have happened to these people. A lot of people found in the population in 2011 could have died. Some of them, particularly Jews, could have migrated, for example, to Israel. So I found a method of updating that particular number of Jews in 2011, bringing it to current times, to the 1st of March, effectively, of 2020. First of all, reducing all the deaths that could have happened since then. And for that particular purpose, application of death rates from Israeli population or even from British population would be sufficient. And also discounting that number, taking into account migrants, migration to Israel from all over the world is very well documented, so I could adjust it also using the migration from the Central Bureau of Statistics of Israel. I then calculated death rates, dividing deaths by the population. And then I did also something else, which the ONS didn't do and couldn't have done. I adjusted the indices for the suspected under-registration deaths. I will talk about it a little bit later. Then I repeated the exercise in essentials, not in every single detail, with respect to Christians, which is our comparative group, basically in an attempt to replicate exactly what the ONS did, only with a proviso or with a specification that I'm doing it for COVID and non-COVID separately, and I adjust for under-registration of COVID-19 deaths. A little bit more detail on that for those of you who prefer graphical explanation. On the left, you can see it's basically a timeline, 2011 census. There's a long chunk of time between that in March 2020, which is colored a gray. Every year, certain amount of deaths are happening, and those deaths in year 11, 12, 13, 14, etc., are reduced. Then there's a certain number of migrants that leaves the population. I reduce them as well, and I recreate the stock on 2000 of Jews on 2020, and then I apply to that stock deaths from COVID and non-COVID in these 2.5 months. Now, the under-registration of COVID-19 deaths. This is not something that the ONS publication and the original one attended to, and they couldn't do so. You will have noticed that very early in the lifetime, in the course of this epidemic, very early on, newspapers and social media started making the point that the true number of deaths from COVID-19 may be higher than we are told. As it happens, some of this became sort of, it sounded a little bit like conspiracy theory, but it was absolutely right in essentials. Not because the government, the big pharma, the state, or anyone else wanted to hide the COVID-19 deaths, but simply because COVID-19 was a novel cause of death. That's one thing. And also, COVID-19 lives and operates in an environment with multimorbidities. And these causes of death are notoriously difficult to capture. I have in a different presentation illustration that effectively COVID-19 in the manner, the ways in which it is captured on death certificates resembles very much our old friend influenza. In influenza, there's no conspiracy theory there. There's no novelty either. It's a very well-established cause of death. It so happens that with certain causes of death, they are simply imperfectly reported on death certificates. Doctors are either unsure about whether to report them, or they think that there is certain test required. And so a certain proportion of COVID-19 deaths makes it into official counts. Others remain unreported, but we can capture them. We can capture them by estimating what's called the excess mortality. And this exhibit shows you how it's done. So there's a small number of COVID-19 deaths which are officially certified with death certificates stating that this is a death due to COVID in one way or another. We also have statistics on all expected deaths from whatever causes in 2020. That's a yellow circle. The expected deaths are basically seasonal deaths that are expected to happen no matter what. And we can look at previous years, 2019, 18, 5 years back, to figure out how many deaths we expect to happen in this season. We then have total deaths in 2020. And when we compare the expected to observed, we end up with an impression which is at the bottom part of the presentation of the slide. They're not completely overlapping. That slither there is the excess deaths due to COVID, and only proportion of them, colored in gray, that proportion is officially reported to us as COVID. The white part of the slither is something that I figured out, and I could apply it. I could use it in my calculation subsequently. It's quite an important point, and I hope to be able to show why. Now, and this is the results. Finally, we come to the results of the reanalysis. I show to you death rates for religious groups, Jews and Christians, just for COVID and without COVID for the specified period. Let's start from the right panel, like we do in Hebrew. And what you see on the right panel is, well, you basically see the ONS result. This is a reanalysis, the results of my reanalysis, which redelivers to you the ONS result. The Jewish mortality from COVID-19 is very high. And the Christian mortality from COVID-19 is half, almost half of what Jewish is. That is COVID-19. Now go to the left panel. And this is mortality of Jews and Christians from cases that are anything other than COVID. Okay? There's a very small difference, if at all. I must also tell you that the degree of Jewish advantage here is underestimated. There is a certain compromise here for technical reasons. First of all, as I said to you previously, I updated Jewish population very diligently with deaths and migration. I could do so with Christians. I could not remove migrants that could have left the population. So my denominator with Christians will be bigger, and so the death rates as a matter of arithmetical necessity will be lower. So we can think about the situation on the left-hand side as equality between Jews and Christians, but it's a very conservative estimation. Now, to the next slide. This is a replication of the previous picture, but right now I also control for the under-registration of COVID-19 deaths. On the right-hand side, what you see is still persistent, unambiguous, uncomplicated confirmation of the ONS message and result. Jews died disproportionately from COVID compared to Christians. What you see on the left-hand side is the confirmation of the 150 years of research where Jewish mortality is lower than non-Jewish mortality. So this result is looking at us, and it's very, very unambiguous. So whatever Jewish disadvantage in mortality that ONS was talking to us about, this was due to COVID purely and nothing else. Otherwise, mortality of Jews is low. And that is the, if you wish, a recast of the same findings. Here, where simpler ratios of Jewish to Christians death rates are shown. This time I also do it by sex. There is no great difference between the sexes, or no enormous difference. So if we start from the left and from the gray bar, this is a ratio of Jewish to Christian death rate from COVID, just from COVID. The light blue is no COVID, all other causes of death. And the dark blue is just all causes of death, COVID and non-COVID included in that. This is a very unambiguous presentation. COVID creates or appeared, well, it is with respect to COVID and just COVID that we see Jewish disadvantage. And we actually see that Jews are, as we expected, as suspected, Jews appear as a group with low mortality compared to Christians. Now, that's the conclusion. COVID managed to affect Jewish population in a way that no other causes of death couldn't. It basically suppressed the underlying low mortality, and it made Jews appear to be as disadvantaged as the BAME, and though they were not. I would like to tell you why now, and I wish I could tell you why. I wouldn't be able to. I will offer some, ultimately I will offer some hypothesis, and I would probably, I would like to see the discussion around the plausibility of some certain hypothesis. But I will tell you one thing. I will tell you what it isn't, if you wish. You will recall that in the beginning, also in the beginning of the epidemic, there was a lot of talk, there still is, about the behavior, the compliance patterns of the strictly Orthodox Jews. To what extent they impact on morbidity and mortality in that population, and also among others, Jews and non-Jews. Now, what I can tell you categorically at this very moment, and that it really is unambiguous, that the results we have seen so far, i.e., strong Jewish disadvantage in COVID mortality, has nothing whatsoever to do with strictly Orthodox Jews. Nothing whatsoever. This is not to say, this is what I'm emphatically not saying, is that everything is fine with strictly Orthodox Jews, that their mortality is as good or as bad as everyone else's. This I simply don't know. But I can tell you that the observations the ONS produced and my reanalysis confirmed and developed have nothing to do with strictly Orthodox Jews, for the simple reason that the proportion of these people in the age group 65 plus, 75 plus, those people who die from COVID really is minimal. You can see here in the exhibit in front of you, distribution of the percentage of strictly Orthodox Jews in total population, Jewish population in England and Wales. In total, we now have 20% of Jews who are strictly Orthodox in Britain as a whole. And British Jewish population is ahead of many others in a degree of heredization. But the picture is very, very unequal when it comes to different age groups. We see that among the children, for example, the proportion of the Haredi is almost 30%, but in the age groups most relevant for mortality, which let's say is 60 plus, their proportion is very, very low. There is no way in which people whose proportion is about 4 to 5% can shape the national picture on mortality, even if their death rates are 10 times as high as compared to other Jews. Their impact at the total Jewish mortality will be completely minimal, negligible really. So if the question is, if you had a question whether or not the Haredi are playing a role, then no. The conclusions are in front of you here, and from this point on, I think the discussion should start. Even though Jewish mortality from COVID is high, it's as high as it is for BAME, Jews are a completely different case. They should be analyzed and understood as such. They do not have the underlying ill health or compromised health issues. The high mortality among Jews is not caused in any significant way by the Haredi. Now, as for the hypothesis for the future, what I'm left with now is, well, what we're thinking about now is perhaps there's a possibility that Jews had simply much higher prevalence of COVID-19 or much quicker transmission of COVID-19 due to contact-rich religious lives or contact-rich social life. We do not know. The 3 and the 4 are our working hypothesis now, but and the final point I would like to drive home, when we consider those hypotheses of either higher prevalence of COVID to start with or quicker transmission, we better focus our mental efforts on the non-Haredi segment, because our findings come from that segment in particular. This is just references where you can trace, well, you can find more of JPR work, my own work. I also have a blog on Times of Israel, and I blog on the matters related to demography and statistics mostly. Thank you very much, and thank you to David for moderating.
Thank you very much, Daniel, and I'm myself. Thank you very much, Daniel. Can you hear me now?
I can hear you, yes.
Okay, thank you. Thank you. There are questions that have come in. Thank you, first of all, for a very clear and remarkable presentation. There are questions about the basic underlying issues of some of the data, and there are also some questions about future advice within the community. One question from Professor Glazer is, what about births between 2011 and 2020? And the other question is, where do you come into your category, the question of non-COVID deaths, which people have avoided seeking healthcare. Is that part of your hypothesis, or is there any information about that point? So there are two questions that were raised.
Yeah. Okay, thank you. I will take them as they come. The question on births, what is revealed by this question is a very sound knowledge of population accountancy. Births, typically, this is our population component, they should be accounted for, not in this particular case. So the attempt that neither myself nor the ONS, what we didn't want to do is to recreate the Jewish population in 2020. All we had to do is to update our census. So all those people who were alive in 2011, this is who interested us, basically. All the deaths, 99.99% of deaths would have happened to those people who were already alive in 2011. So with births, we simply didn't have to take them into account. These people would have been the oldest of them, 9 years old, let's say. So that's the first question. The second is on the consequences, possible consequences of delayed care with respect to other causes. There is no information on that whatsoever, I must say, whatsoever. And it's not entirely clear to me when these kind of the research exercises should be carried out, how much time should be allowed past the event, so the effects of the delayed care could be measured. It is something to look for. I mean, it's a line of research certainly to develop in the future.
The other question arising from your quotation from Kant, from Dr. Kafetz, was, do the Jews who practice customs that cause avoidable deaths not identify as Jews so they don't get counted? So the ones who are behaving themselves and not getting drunk don't also count themselves as Jews, for example.
Sorry, you would have, David, you would have to repeat it because you were slightly breaking in the middle.
Sorry, do the Jews who practice customs that cause avoidable deaths not identify as Jews so they do not get counted?
Quite possible. Quite possible that by this time, but also during Kant's time, when we talk about Jews, we're talking about some sort of population that had gone through a process of selection and self-selection. That is quite possible, yes.
Okay. There's another question about the demographic basis, which is one that's which I've also wanted to ask, of course. We know that being a care home resident put an individual at a much higher risk of death. Do we know if the percentage of care home residents in the UK is disproportionately high amongst the Jews?
Yeah, thank you. The answer to this is this. This is our next research issue, really. First of all, I checked. One thing that I have done is I tried to ascertain the sheer proportion of Jewish people in care homes, whether that statistic is different or similar to the general picture. Because ultimately, if there are more Jews in care homes than non-Jews, so that may be part of the answer, because the epidemic hit the care homes. It may not have hit Jewish care homes or Jews in particular, but because there's a higher proportion of Jews there, it could have happened. It doesn't appear like it. It doesn't appear like this. Although our data are dated, I mean, it's from census 2011, it's 9 years old. But what we learned from this is that about 30% of people in 65 plus age bracket are in care homes, Jews or non-Jews. Whether there's anything in particular that was happening in care homes, we still don't know, but we are working on it. We are now part of the larger project that the ONS conducts with us to understand who was and who wasn't in care homes in their data set. They can mark these people.
Right. So the care home is being investigated, and
it is being investigated.
And because, as you know, JPR has commented on the Swedish situation where the care homes played a significant role. And a related question also about the composition of the sample is how do British Jews actually list their ethnicity? What is their information about that? Because there are people who register and regard themselves as white British, and that's the way they would be recorded in a census. What is the information about that?
So in 2001, when the question on religion, and I'm purposefully starting with this, when the question on religion was introduced for the first time, there was no end of discussions about how Jews should be accounted for. Is the religion the appropriate question to ask about Jewishness? Would ethnicity be better, for example? Are both needed? And at the time, JPR at the time didn't include me, but the person who advised them was very similar to me in mental makeup, I should say, in demographic background. And he said that the best method to know how many Jews are out there is to ask two questions. One, do you have Jewish religion? Are you, also to ask a religion question, allowing for Jews to identify, self-identify? And the other question is the question on ethnicity, where Jews would tick that box as well. Everybody would choose, a lot of people would choose both. Some people who feel strongly about being religious Jews or ethnic Jews would choose one of them. And we will create subsequently a combined estimate, as this has been done already in Canada, for example. Now, this advice was not followed. The religion question prevailed. And Jews are asked about, the question on religion is asked, and Jews identify themselves very well. They may not feel that it's perfectly fitting them, i.e., they may not be religious, for example, but they know that this is how they should self-identify. Now, what makes me so confident in saying that is that partly due to the ONS, recent ONS work on that, partly due to the various surveys that JPR conducted, we asked people how they identified themselves in census. We asked them in repeated surveys. And what we found out is that absolute majority of Jews, more than 80%, self-identified as Jewish in the census. So we have a very good idea, genuinely very good idea about how many Jews are in the UK from a religion question. We also found out, and I will not go into detail, great detail about it now, that those Jews who did not identify themselves in religious terms as Jews in census also typically do not partake in Jewish rituals. So if they opt out in many senses. We know about this population. They exist on the margins of Jewish community. And the comforting thing about them, comforting for demographer, is that their behavior is extremely consistent. If they're not in the census, they typically are not buried through the burial societies. They typically also don't circumcise their children, or let's say a large proportion of them do not. We have a confirmation of this from the census. So that's basically our life. The religious question captures adequately Jewishness. There are margins, socially significant, demographically less significant, and the sizes of them are known to us.
There's also a further question, again, on the question of the demography. Could you perhaps explain the 939,921 figures? The unregistered COVID deaths affected the Jews more than the Christians. Hello?
Yes, I'm now, I think, what I'm trying to do is to share the presentation. It may or may not succeed. Let us see.
If you could explain that, right?
That is it.
Yeah. Yes.
Yeah. So the 939 is a simple death rate per, 100,000. I did it for simplicity. This represents the number of people, Jewish people, who, or Jewish deaths per 100,000 of Jewish population from all causes that are not COVID-19. A parallel figure, 921, is the death rate per 100,000 for Christian population. We can see that, for Christian population here, it's very slightly lower. than among Jews. Well, the key point here that this, well, near equality, these bars are nearly equal in size. And this picture on the left contrasts very strongly with the picture on the right, where Jewish mortality captured by 734, which is the death rate per 100,000, contrasts very strongly and favorably with a Christian mortality captured by 332 deaths per 100,000. Is I hope that's clear. I'm prepared, by the way, to whoever feels like they want to have a greater insight into all of that, both figures and the method. I would be very happy to talk to people in privately.
Right. Okay. The question is how does this compare with slide 17?
Sorry, say this again, David.
How does this compare with the next slide, with slide 17?
Yeah, this is it. So now what we can see here is this. If we start from the right here, what we saw before, if I click, very quickly flick. Okay, on the right is 734, 332. A tremendous Jewish disadvantage with respect to COVID. Here, the Jewish figure is 941. The Christian is 426. The tremendous disadvantage with respect to COVID persists. On the left-hand side, what we can see that Jewish bar is now shorter than the Christian bar, and the number is smaller. What we can see here is that the non-COVID mortality from absolutely everything, just not COVID, among Jews is lower than it is among Christians, and significantly so. The COVID remains as bad as it was, but the non-COVID, basically, if there wasn't a COVID this season, okay, the right panel wouldn't be possible. It wouldn't be possible to create it. If somebody asked me, how do Jews compare to Christians, okay, in year 2019, for example, the presentation, the graph on the left gives you that answer. That is, give or take, 2019. You would see that Jewish mortality is simply lower by 20%, something like this, than non-Jews. And that is a very classic finding. I would say if I delivered it at the demographic conference, it would be most unexciting finding, let's just say. We're used to it. The COVID-19 disadvantage is the real puzzle.
Okay, that's a very sobering slide, which raises the question, are there any comparative observations in other countries, United States, Israel, France, any other countries, and any similar demographic data has yet been done?
This is an opportunity for me to share this in parallel to the reanalysis and development of the ONS work. We launched a project of the global of Jewish mortality from COVID, where I contacted different Jewish burial societies across the world, literally. I received to date data from the United States of America, Canada, the European communities, and from Israel. And we use a slightly different method of estimation, different from the ONS. The resources are very different, the methodological possibilities are different. But anyhow, in due course, I would say in a month or two, we will be sharing those results as well. We are aiming to create a global picture of COVID and non-COVID mortality across Jewish communities.
There's one other question relating to the previous slide that's come up now, and that is when you talk to the Christian population, is the non-Christian population, or is this just the Christian population that are declaring themselves as Christians?
Yeah, it is just Christian population in this particular case. The reason it's rather unproblematic for now in this day and age, and it may change in the past, that among people who are 65 years and over, first of all, most people report some sort of religion. And the majority of British population in these age groups, not perhaps not across all age groups, but in these age groups, is Christian. So the Christian mortality is that yardstick, or if you wish, benchmark, which is a very reasonable to adopt.
And then the one question about the future is really an important question, and we'll take that one now. How should Jewish healthcare workers be assessed on NHS COVID risk assessment in the light of this? Should being Jewish count as a risk in the same way as BAME and integrated into the risk assessment for them, which is now, of course, a mandatory assessment throughout the NHS? And of course, this is an important question because in 2 weeks' time, we'll have, 10 days' time, we'll have young Jewish doctors entering the workforce. What should this be something that they have to have in their risk assessments?
I think in this particular case, I will make a very scientific statement. If this was left to me to decide, I would be rather safe than sorry. Sometimes, let's just say, to solve this issue completely, we need to have an absolute insight into why Jewish mortality from COVID is high, as simple as that. What is the mechanism that generates that outcome? In order to solve the problem, fundamentally, you need to define it first. You need to understand the roots of that. This is not something that I can do. And if we're talking about, the framework you're talking about probably is a few weeks' time, I cannot be or anybody, ONS or epidemiologists can deliver a definitive description, a definitive explanation. Now, if we see elevated mortality of Jews from COVID for reason unknown, I would probably take this at the face value. So first of all, it's a very real result. There's some sort of vulnerability to COVID. It is not due to vulnerability which underlying ill health, but it is there nevertheless. So I think I would that's how exactly I would use it. I would rather be safe than sorry. And, we don't know why, but do we have to? For the purpose of this particular policy.
So you would suggest that it should be included in risk assessment for that reason?
I would say that it's a very real result. One thing that I'm emphasizing now, that it's a real rather than a fluke, rather than an error, is this. When we first received these results, when I first read the report from the ONS, my first response, the gut reaction of the demographer was, that's not right, that's an error. The result looked so absurd compared to everything I knew from the literature on Jewish demography, which is not young, which is very respectable, really going back about 200 years, that my first suspicion was literally that their labels slipped somehow. The Jewish label was replaced in Jewish, some sort of, it actually is a Muslim rate, for example, but their label slips. And this was my first reaction. Now, since then, having checked and reanalyzed data, we know that the result is real. It is a completely actual result that we have elevated COVID mortality among Jews. And I think for immediate, in terms of immediate policy implications, we can leave the why aside in a way. We want to protect people in the immediate term. We can postpone the why till better times. Right. That would be my take on it.
And the two very final questions that relate to that were antigen testing outside. In other words, the test for the PCR test outside hospital. It doesn't include religion. when that is done. So you should have a large body of data excluding religion and then be able to take the religion ones into account after that. Is that correct? That when you register, when you have your test done, nobody records your religion.
I would, well, I don't know, but I would believe you very easily that no one records your religion. I'll tell you more, religion is not a type of information, or ethnicity indeed, that is routinely collected in the official records. Even if they do, for example, when you register with a GP, you asked about ethnicity at the very least, at last time, but somehow they make it clear to you on the form that it's not a mandatory question, okay? So this information is not collected in a very routine way. And I think if there is a serious interest in drawing profiles of differential fertility, religion and ethnicity has to commence in seriousness, in earnest, and in a few years, we will be in a different situation. We will be consuming the fruits of that process, but it will take a few years.
Questions start to pour in, and the questions now say, is there genetic predisposition? And also, have you any information about the people who have survived from this and managed to cope? And very finally, when is the next reporting period? When are we going to get the next episode from the ONS for you to analyze?
I would say this. With respect to people who survived COVID, I mean, I'm a demographer, and I'm not a doctor. So in a way, I would expect to learn from this audience about their experiences of the disease. Our work with, so I would expect to learn about the disease, but I have nothing to, there's nothing in me, in my professional background, that can enhance your insights into that. Quite the opposite. Our work with ONS is ongoing, and we expect to have some more data on the same topic of religious differences in mortality, Jewish situation with COVID in the early autumn. We also, as I mentioned before, expect to publish a major publication on Jewish mortality from COVID on global scale. Now, these were two questions that I addressed, but I have missed the first question in this series, David. So would you kindly repeat?
Genetic predisposition.
Yeah. So I can tell you that throughout my entire career, really, with respect to every single cause of death, every single morbidity, within the context of Jewish mortality, this question is asked. And what I can tell you is this: it's not something that I can dismiss completely, but there's a very important observation that I would like to share. The extent of Jewish disadvantage from COVID, which is ×2, basically. The Jewish mortality from COVID is 2 times as high as non-Jewish. That extent of disadvantage, I have never seen that being explained by genetic influences. Genetic influences exist. They're very well documented, not just in disease and various characteristics, lactose intolerance, for example, height, physical characteristics that can affect health. There's no doubt about that. I have never encountered in the entire career, which is 20 years now, an instance where genetic predispositions and biological differences could shape the picture of mortality in this tremendous way. They only, to give you an idea of what it looks like, the difference of 2 times, okay? The only thing that is similar to that is the difference between smokers and non-smokers in cardiovascular diseases. The difference between non-smokers and smokers in cardiovascular diseases particularly is about 2 times, something like this. The smokers' death rates from cardiovascular diseases are twice as high. So this is a very strong environmental factor. People do something to their health. This is what generates this kind of differences. Something that people do, and I dare say, something that is almost under our nose. We are looking at something without recognizing its importance. In the case of COVID, the differences. That's something like this, some sort of behavior, some sort of environmental factor, structural factor. We simply do not comprehend that properly. Genetic differences, as I said, may or may not be. It wouldn't be my first place to look. That's the best way to put it.
Well, I think that we've certainly had a tour de force taking us through the data and answering numerous questions, and we're very, very grateful to you for the time you're spending on this, and for which is a very important subject, and for having spent the time with us this evening. This is just to say to everybody who's here tonight, and that next week we're going to be having an update report on what's happening in Israel at the moment, and from Professor Paltiel. And so I hope, Daniel, you may be able to join us as well, but I hope everybody will find that also of interest. Thank you very much, Daniel, for really a wonderful presentation and for coping with numerous and complicated questions. Good night, everybody.
Thank you. Thank you. It's an honor to be with you.